Imagine suffering from this just debilitating daily pain for years, only to find out that the exact biological process that is aging your heart and stiffening your arteries is, well, it's the absolute only thing that cures it.
Yeah, it's a completely wild concept.
It really is. Today, we are unraveling one of the most perplexing paradoxes in the human body. We are looking at a stack of incredibly fascinating medical sources for you today.
Right, we've got everything from clinical management guidelines and hospital patient leaflets all the way to these really dense, deep vascular biology papers from journals like Frontiers in Physiology and MDPI.
Exactly. And our mission for this deep dive is to explore a condition that affects an enormous number of people, yet it somehow remains highly underdiagnosed.
Which is tragic, really.
It is, and it all centers around a single hormone that acts as this seemingly miraculous cure for chronic pain, while simultaneously, setting a trap for your cardiovascular system.
It is a biological tightrope walk, to put it mildly. We're looking at how estrogen dictates the clinical management of a condition called pelvic congestion syndrome, or PCS.
PCS, right?
Yeah, and depending entirely on where you are looking in the body, this hormone functions as both a creator of disease and a profound protector of health.
I'm going to start with the sheer scale of this, because the clinical guidelines we're reviewing note that PCS accounts for up to 30% of all chronic pelvic pain cases.
That's a massive chunk.
30%. Yet, reading through the patient accounts, you see women suffering for years, going from specialist to specialist, before ever even hearing the name.
Yeah, it happens all the time.
Why is it so incredibly hard to diagnose if it's that common?
Well, the diagnostic hurdle really comes down to anatomy and gravity, honestly.
Gravity.
Yeah. Okay, let's unpack this to transition into the foundation of what PCS actually is. At its core, PCS is essentially a vascular issue. We are talking about varicose veins.
Like the ones people get in their legs.
Very similar to the ones people get in their legs, yeah. But these are located deep inside the pelvic cavity, primarily the ovarian veins and the internal iliac veins.
Okay, so they're completely hidden.
Right, because they are hidden deep in the pelvis. You can't just see them with the naked eye. But here's the gravity part. When a patient lies down flat on an exam table for a standard pelvic ultrasound, the blood just drains out of the pelvis.
Oh, because they're horizontal.
Exactly. The veins collapse back down to a normal size, and the primary evidence of the disease completely vanishes from the monitor.
That is incredibly frustrating. I mean, you are literally lying there in pain, and the machine says you are perfectly fine because the physical act of lying down hides the problem.
It's precisely why specialized imaging is so crucial. You often need a transvaginal ultrasound performed while the patient is actually standing upright or bearing down just to catch it.
Because that forces the blood back into the veins.
Right. And to understand what the ultrasound is even looking for, we have to look at the mechanics of the vein itself. In a healthy vein, you have these tiny one-way valves.
Like little trapdoors.
Yeah, exactly like trapdoors. They push the deoxygenated blood up against gravity, back toward the heart. But in PCS, those valves are faulty or damaged. They just fail to close.
And when they fail to close, the blood just reverses course.
Yes. That backward flow is clinically referred to as venous reflux. Because the blood is flowing backward and falling with gravity, it begins to pool in the intricate network of pelvic veins.
Which is where the congestion part of the name comes from.
Right. Those vessels become congested, severely dilated, and just heavily engorged with stagnant blood.
I was reading through the hospital leaflets, and the reality for the patient is just brutal. The primary symptom they look for is this persistent, dull, dragging ache in the lower abdomen or pelvis.
And it has to last for more than 6 months to meet the criteria.
Right, and because it's driven by gravity and that pooling, it progressively worsens throughout the day, especially if you're standing for a long time.
Yeah, cashiers, teachers, anyone on their feet all day really suffers.
And it also frequently causes severe pain during or after intercourse, which the literature calls dyspareunia.
It's a very heavy symptom burden, and if we look at the demographic data in the guidelines, this primarily strikes women of childbearing age.
So typically between 20 and 45 years old.
Yep. And the most significant risk factor by far is having had multiple previous pregnancies.
Okay, I want to pause on that pregnancy connection because I'm trying to picture the physical reality of what is happening inside the pelvis.
There's a lot of physical change.
Right, because during pregnancy, a woman's total blood volume drastically increases. And the pelvic veins have to expand massively, sometimes up to 50%, just to handle that extra flow.
They do, yeah.
So is this like overstretching a balloon? If pregnancy increases blood volume and the veins have to expand that much, do the valves just lose their snap, like an old elastic waistband?
That is a highly accurate way to visualize the mechanical stress. The physical stretching absolutely damages those delicate
So
valves.
they just can't close tight anymore.
Right. But what's fascinating here is that if we look at the cellular level, the stretching isn't just physical, it is fundamentally chemical.
Chemical. How so?
Well, the veins aren't just being forced open by the sheer volume of the blood. They are being actively commanded to relax. And this brings us to the real driver of the condition, which is high estrogen.
Ah, because pregnancy is essentially a massive systemic flood of estrogen.
A profound flood. During the reproductive years and intensely during pregnancy, high levels of estrogen actively change the behavior of the blood vessel walls.
Okay.
Estrogen stimulates the endothelial cells, which are the cells that form the very inner lining of the blood vessels. It prompts those cells to produce potent vasodilators.
Things that widen the blood vessels.
Exactly. And the most prominent of these is nitric oxide, or NO. Nitric oxide is a gasotransmitter that signals the smooth muscle inside the vein wall to relax and expand.
Okay, so wait, let me make sure I have this right. During a pregnancy, the estrogen is actively relaxing the elastic of the vein to accommodate the extra blood.
Yep.
But if you have multiple pregnancies and those veins are constantly bathed in high estrogen and nitric oxide, do they just become too wide and too floppy to function properly once the pregnancy is over?
That is the exact mechanism. The constant high estrogen environment makes them highly flexible and prone to that exact blood pooling and valve failure we talked about.
Wow.
Yeah, high estrogen essentially creates the perfect, relaxed vascular environment for pelvic congestion syndrome to take hold and just thrive.
Which brings us to the absolute core focus of our deep dive today. If high estrogen and the physical strain of pregnancy are what stretch these veins out and create this agonizing pooling, what happens when that hormonal engine shuts down?
That is the big question.
Right. What happens when a woman hits menopause?
This is where the clinical data presents an incredible paradox. According to the sources we're reviewing, pelvic congestion syndrome is practically unheard of in postmenopausal women.
I kept rereading that line in the clinical guidelines. Practically unheard of.
It's a striking detail.
You have a condition responsible for up to 30% of chronic pelvic pain cases, and then it just vanishes. How exactly does that drop in estrogen physically shrink these veins back down?
To understand the cure, we have to look really closely at the biology of the decline. In that vascular endothelium we just mentioned, there are specific classical estrogen receptors.
Okay.
They are known as ER-alpha and ER-beta. Now, during a woman's reproductive years, circulating estrogen constantly binds to these receptors.
Keeping the nitric oxide flowing.
Exactly, which keeps the veins relaxed and wide.
But once menopause hits, the ovarian estrogen production completely tanks. The signal is just gone.
It's gone. And without estrogen actively binding to the ER-alpha and ER-beta receptors, there is a dramatic, sharp drop in the production of those vasodilators.
So no more nitric oxide telling the veins to relax.
Right. Without that constant chemical signal, they lose their extreme flexibility. They begin to stiffen. But more importantly, they shrink back down.
And when they shrink,
As the veins shrink and lose their elasticity, their capacity to hold large, heavy pools of stagnant blood diminishes completely. The profound pooling that stretches the nerves and causes that deep, dull PCS ache is just halted in its tracks.
I want you, the listener, to really sit with this paradox for a second. The natural biological process that makes us age, the very mechanism that makes our blood vessels stiffen up and lose their youthful flexibility, is the exact process that cures this debilitating chronic pelvic pain.
It's completely counterintuitive, but it's true.
It's fascinating. But how does this translate to clinical management? If a patient is, say, 35 in severe pain and decades away from natural menopause, how do doctors actually use this information?
Well, they use it to build a roadmap for treatment. The medical management of PCS heavily relies on pharmacological approaches that intentionally mimic this biological drop in estrogen.
So they fake a menopause.
Essentially, yes. If they know estrogen is the fuel, they use medications to artificially induce a temporary state of menopause.
What kind of drugs are we talking about?
The guidelines highlight drugs like gonadotropin-releasing hormone agonists, often called GnRH agonists, or specific high-dose progestins.
I was trying to understand the actual mechanism here, because when you say artificially induced menopause, it sounds like just flipping a switch. How do these GnRH drugs actually force the ovaries to shut down?
It is actually a fascinating, almost backward mechanism. Normally, the hypothalamus in the brain releases GnRH in short, rhythmic pulses.
Like a heartbeat.
Yeah, exactly. These pulses tell the pituitary gland to signal the ovaries to make estrogen. But a GnRH agonist doesn't pulse. It provides a constant, overwhelming flood of the hormone to the pituitary gland.
So it basically overloads the system.
Yes, it completely overloads it. Initially, the pituitary gets overstimulated, which actually causes a brief, massive spike in estrogen.
Oh, so the pain might get worse at
The
first.
patient might actually experience a temporary flare of their pelvic pain, yeah. But very quickly, usually within a week or two, the pituitary essentially gets exhausted.
Just gives up.
It downregulates its receptors, it stops responding entirely, which completely cuts off the signal to the ovaries.
Wow.
The estrogen production plummets, the pelvic varices shrink, and the pain is relieved without the patient ever needing surgery.
So what does this all mean? It's like a plumbing issue. Instead of continually mopping up the floor because of a leak, hormone therapy just turns off the main water valve.
That is a perfect analogy.
But as effective as that is, pushing a 35-year-old woman into menopause brings hot flashes, bone density loss, mood changes. I mean, the side effects are heavy.
They are significant, yeah.
And some patients just can't tolerate that, or maybe they're actively trying to conceive.
Uh-huh.
So if we can't just blow the estrogen fuse, what is the procedural alternative?
That is when the interventional radiologists step in. The primary procedural approach detailed in our sources is ovarian vein embolization.
Embolization, what does that actually look like for the patient?
It's a minimally invasive procedure. A specialist inserts a catheter, a very thin plastic tube, usually into a vein in the neck or the groin. Using real-time X-ray guidance, they thread this catheter all the way down through the body and right into the faulty pelvic veins.
All the way to the broken trapdoors.
Right. And once they are inside the dilated leaking vein, they block it off permanently. They deploy tiny metal coils or they use a special sclerosing foam to completely plug the broken vessel.
So they are essentially barricading the broken road, so the blood is forced to find a different, healthier route back to the heart.
Exactly.
But looking at the clinical data in our stack, I noticed a pretty significant catch. Embolization is generally considered very safe, but the symptom recurrence rate is somewhere between 10 and 40%.
It is, yeah.
If you've permanently blocked the broken vein with metal coils, why is the pain coming back in almost a third of patients?
Because the vascular system is incredibly adaptive. The pelvic region has a deeply complex, interconnected network of collateral veins.
Like side streets.
Side streets, exactly. If you block off one major faulty vein, the blood will absolutely find another route.
Oh, I see.
But over time, the increased volume and pressure on those secondary, smaller collateral veins can cause them to stretch, dilate, and become varicose as well.
So the original broken road is closed, but now the detour route is falling apart under the strain, bringing the pain right back.
Precisely.
Which makes sense. If the underlying chemical environment, that high estrogen, is still actively telling the veins to relax, they're going to keep stretching.
Right. The systemic issue is still there.
Which leads to the absolute most extreme option on the table, the surgical removal of the uterus and the ovaries, a hysterectomy and bilateral oophorectomy.
It is the final resort for a very good reason.
Because it forces the patient into immediate, sudden surgical menopause.
Yes, it permanently removes the source of the estrogen and physically removes the target organs. But the data from the medical literature is quite sobering.
It really is.
Even with this irreversible measure, there is a massive 20 to 33% risk that the patient will continue to experience lingering residual pelvic pain.
That is devastating to read.
Yeah.
I mean, you undergo major abdominal surgery, you lose your reproductive organs, get thrown into instant surgical menopause, and a third of the time, the pain doesn't even go away. Are the nerves just permanently damaged at that point?
It is highly likely a combination of central nervous system sensitization, where the nerves have just been signaling pain for so long that they become trapped in a feedback loop, and the presence of those tiny collateral veins we discussed.
The detour veins.
Right, those might still be engorged even after the major organs are removed.
And that surgical menopause brings us to the massive glaring complication in this entire story. We've clearly established that a drop in estrogen, whether it's natural, pharmacological, or surgical, is fantastic for curing leaky, dilated pelvic veins.
It is the cure, yes.
But the Frontiers in Physiology research highlights a terrifying double-edged sword regarding the rest of the body's circulatory system.
This is the crux of the estrogen paradox. The exact same estrogen drop that cures pelvic congestion syndrome wreaks absolute havoc on the arterial system.
Because the veins and the arteries, react to the loss of this hormone in entirely different ways.
Completely different ways.
Because throughout a woman's reproductive years, estrogen is profoundly protective of the heart.
Profoundly protective. Just as estrogen tells the pelvic veins to relax and widen, it is doing the exact same thing in the coronary arteries.
Okay.
Keeps the arterial tree highly flexible, it reduces local inflammation, and it actively prevents atherosclerosis.
Which is the dangerous buildup of plaque.
Exactly. And it achieves this arterial health largely through that same chemical pathway we discussed earlier. It stimulates the endothelial cells to produce nitric oxide.
But when menopause hits and the estrogen disappears to cure the pelvic pain, the heart just loses its primary shield.
Yes. When estrogen declines, women lose that protective wash of nitric oxide in their arteries. This leads to a condition called endothelial dysfunction.
Meaning the arteries lose their youthful flexibility.
They stiffen, and because of this arterial stiffening and the subsequent loss of protection against plaque, a woman's cardiovascular risk skyrockets.
Even if it was super low before.
Yeah, historically very low prior to menopause. But post-menopause, a woman's risk for cardiovascular disease rises to match or even exceed the risk in men of the very same age.
Here's where it gets really interesting. This sets up an incredibly difficult clinical dilemma for you to consider. Imagine a woman who has suffered for a decade from severe pelvic congestion syndrome.
Okay.
She finally hits natural menopause, and the pelvic pain magically vanishes because her estrogen dropped. She finally has her life back.
Right.
But now, she's facing this massive, skyrocketing cardiovascular risk. Her doctor suggests hormone replacement therapy, HRT, to give her back a controlled amount of estrogen to protect her heart, her brain, and her bones from rapid aging.
Which is standard practice.
But if she takes HRT to save her heart, won't that systemic estrogen travel right back down to her pelvis, relax those stiffened veins, and bring back her agonizing PCS symptoms? Are we really telling women they have to choose between a healthy heart and chronic pelvic pain?
It is one of the most profound clinical conundrums in women's health, honestly. And it highlights the delicate reality of menopause management.
So what happens?
Theoretically, yes, systemic estrogen replacement could absolutely redilate those pelvic veins and cause severe symptom recurrence. Both high and low estrogen levels dramatically affect vascular health, just in completely opposing ways depending on the vessel.
So how do vascular experts navigate that? How do you balance the scales?
Well, the clinical literature relies heavily on something called the timing hypothesis regarding HRT.
The timing hypothesis.
Yeah. It suggests that the estrogen-mediated benefits for the cardiovascular system only occur if the hormone therapy is initiated very early in the menopausal transition.
Oh, before the damage is done.
Right, before the detrimental effects of age, like severe arterial stiffening and hard plaque buildup, are permanently established in the vascular walls. If you wait 10 years after menopause to start HRT, the arteries are already structurally damaged.
So adding estrogen back then won't help.
It won't reverse the damage, and it might actually increase the risk of blood clots.
So the window of opportunity is tight. But what about protecting those delicate pelvic veins during that window? The sources mentioned utilizing transdermal patches instead of oral pills to manage this risk.
Yes.
I didn't fully grasp the distinction when I was reading it. Why does the delivery method matter so much if it's all just estrogen entering the body anyway?
It all comes down to liver metabolism. When a patient takes an oral estrogen pill, it has to pass through the digestive system and the liver before it ever reaches the bloodstream.
Okay.
This is called the first pass effect. When the liver is suddenly hit with a high dose of oral estrogen, it reacts by pumping out coagulation factors.
Proteins that increase blood clotting.
Exactly. For a patient with a history of PCS who already has sluggish, pooling blood in their pelvic veins, increasing their blood's tendency to clot is incredibly dangerous. It can lead to deep vein thrombosis.
Oh, I see. But a patch bypasses the liver entirely.
Exactly. Transdermal estrogen, like a patch or a gel applied directly to the skin, absorbs directly into the systemic circulation.
Skipping the digestive system.
Right. It avoids that massive liver first pass effect, meaning it doesn't trigger that dangerous spike in clotting proteins. It offers a much gentler vascular profile.
That makes a lot of sense.
Doctors might also pair that transdermal patch with specific, carefully chosen progestins that help counteract the extreme vasodilatory effects of the estrogen on the veins, but it requires meticulous, personalized monitoring.
Because providing just enough estrogen to keep the coronary arteries youthful might just be enough to make those pelvic veins sick again.
It is a constant game of biological trade-offs.
It really is. To synthesize this journey for you, the listener, we are looking at a single molecule, estrogen, that serves as the fountain of youth for the heart, but the absolute architect of destruction for the pelvic veins.
It's quite the resume.
We've seen how PCS is driven by the very hormone that keeps the cardiovascular system healthy. We've seen how the natural aging process and the specific decline of estrogen essentially acts as a biological cure for the disease by stiffening those leaky veins.
Right.
And we've explored how modern medicine attempts to balance this tightrope using drugs to mimic menopause to stop the pain while struggling with the reality that removing estrogen completely strips away the heart's primary defense system.
The clinical management of PCS is inextricably linked to the patient's hormonal timeline. Understanding exactly where a patient is on that timeline, whether they are premenopausal and flooded with estrogen or postmenopausal and experiencing estrogen withdrawal, is the absolute key.
The key to everything.
Yeah, the key to understanding both their symptom severity and the delicate balance of their treatment options.
It is a massive amount to process.
Right.
But it makes so much sense when you break it down to the mechanics of the vessels and the specific chemical signals commanding them. But before we wrap up today, I was reading that MDPI paper from our stack, and I mentioned a secondary gas involved in this process. Hydrogen sulfide. I couldn't wrap my head around that. Isn't that the toxic gas that smells like rotten eggs?
It is.
What is that doing inside our blood vessels, and why does it matter for the future of PCS?
Well, it does smell exactly like rotten eggs, but inside the human body, produced in microscopic amounts, hydrogen sulfide, or H2S, acts as a very powerful local vasodilator. It functions much like nitric oxide.
Oh, interesting.
And the MDPI research highlights a critical discovery. Estrogen doesn't just trigger nitric oxide, it also triggers H2S.
Okay.
And crucially, this H2S production is specifically and heavily augmented in the uterine and pelvic arteries and veins during high estrogen states.
So estrogen is using two entirely different gasotransmitters to relax the vessels, but the H2S is highly localized to the pelvis.
Yeah.
Why is that a game changer for treating this?
Because it offers us a highly specific target. Right now, to treat PCS, we have to use blunt force systemic hormone suppression.
Right, the GnRH drugs.
Exactly. We use GnRH agonists to shut down all the estrogen, which cures the pelvis but starves the heart and the brain.
Yeah.
But what if the future of treating conditions like PCS isn't about suppressing estrogen at all? What if, instead, pharmaceutical researchers could create targeted drugs that only inhibit hydrogen sulfide locally, right there in those specific pelvic veins?
Wow. If you do that, you could leave the systemic estrogen completely alone.
That is the frontier we are looking at.
Yeah.
You could locally block the H2S in the pelvis, stiffening those faulty veins and stopping the agonizing PCS pain.
While leaving the rest of the body's estrogen supply and its systemic nitric oxide production perfectly intact to protect the heart, the brain, and the bones.
Exactly. We could completely sever the paradox. We wouldn't have to force women to choose between pelvic comfort and cardiovascular longevity.
That is an incredible thought to leave on. To think that the key to solving this massive underdiagnosed source of chronic pain might just be a tiny, stinky molecule acting locally in the pelvis.
It's pretty amazing.
It really brings us back to the reality of the human body. It isn't a simple machine. It isn't a clean X-ray with a single broken bone. It is a complex, mysterious, muddy landscape of competing chemical signals. And unraveling those signals, one gasotransmitter at a time, might just be the key to giving millions of people their lives back. It makes you wonder what other cures are hiding in plain sight, just waiting for us to understand the local chemistry. Until next time, keep diving.